providers can spend a couple hours in an administration building or in a billing class to understand what they do. All right, and it is important. Talk about medical necessity. You know, they know medical necessity in and out, but they need to understand what you're trying to explain. They certainly review the PCS if one is applied. They code the claim. They submit the claim to the payer.
What's PCS?
Patient care or physician certification statement.
Okay.
You
It's
might
the same
notice
thing as the medical necessity.
PMNC,
I'm
physician's
just
medical
making sure I'm in
necessity.
the same ballpark.
They code the claim, they submit it to the payer, and then they manage it through accounts receivable and they track it. So it's really nice, right? So they submit this, you know, we run a call, take the patient to the hospital, complete the chart, lock the chart, it goes out into Never Never Land, they grab it, verify all that stuff, send it off to the payer. Well, when that patient calls in 2 weeks to complain because they got a bill, they have track progress, so they can go in there and they know exactly when they talk to that patient or that client or patient for how long. So then when that patient doesn't like their answer and calls me as the EMS director, I call them and say, can I have the progress notes on that? And then when Mrs. Smith tries to call me a liar, I can say, no, unfortunately, ma'am, I know exactly when you called and when they talked to you. So they do a really good job of tracking those claims as they go through. And the whole idea is run the call, do the chart, submit the claim, get paid. If it were only that easy. Okay. So what they do at QuickMed is they didn't reinvent the wheel, right? They really operate on like a checklist, like pilots do before they, like Sully did when he was landing on the Hudson, that kind of thing. Just go through the checklist. So we don't reinvent the wheel. We just pilfer from other people. So this is what they go through. Every submission that comes into their little department, their little cubicle, this is what they look at. Is it completed? Is everything attached to it? Is it signed? Does it have adequate documentation for medical necessity? Did they document the loaded miles? Was the patient transported to the closest facility? Qualifying signature. What's a qualifying signature? Does anybody know what that is?
Guarantor responsible.
Right, it's the patient's signature or a legal responsibility. We'll get into that. Was it dispatched as an emergency? How did the ambulance respond? Where and how was the patient found? Did they need a PCS? If I haven't, and they did need it, was it signed and dated? And if they were transported to a higher level of care, what's the reason? And then is there clear documentation supporting the claim? All they can see is what pops up on their little computer screen, right? It's not like they're calling you frontline people and saying, hey, by the way, what would you do with this? Or well, how did that happen? They can't do that, right? They submit, I think it's just over 1 million claims a year for, I think it's almost 100 clients nationwide. So it's inconceivable to think that they would be able to do that. But every time a claim comes across the desk, this is what they do. So let's talk about the patient care report. This is absolutely the most integral part of the process, right? This is what sort of ties it all together. And it is one of the most important responsibilities you have as field providers. What, if you had to guess, an EMT and or paramedic class, what would you say was the amount of time spent on proper documentation? What was that?
Very little.
Right. Right. If you went through EMT class, maybe you got 15 minutes. If you went to paramedic class, maybe you got 60 minutes.
Okay,
Half an
times
hour
have
to
changed.
go through the chapter.
Right.
Yeah, times have changed.
As far as what?
Well, as far as the way they're training, because I've been
4 hours.
4 hours?
More than that.
I didn't get that.
I got
My medic
about
class-
a full week because we were told straight up that. Well, I remember the point in line. If it's not in the narrative, you didn't do it, and if you didn't do it, you lose your license.
So you
We
write it
spent
off.
about a week on it, but they don't do that anymore here.
I spent
They don't do anything
My
like
teacher
that.
is like, oh yeah, you're gonna have narratives. They'll probably tell you how to do them when you get hired.
Right. So what employers cannot do, they can't tell you what to put in the chart. That's illegal. They can tell you how to write it and what should be in there, but they can't tell you what to write in the chart. So close your ears. If she's telling you that,
Have I ever told any of you that?
Absolutely.
not, absolutely not. Is what it means. All right. But so the point here is that we don't get that education. We don't get told, hey, here's why it's responsible. Or here's why it's essential to what we do. Right? When I started in EMS in 1993, I had no idea how they got paid, and really, I didn't care. I didn't care. Right? And I was doing it for free. Like, getting up in the middle of the night, sleeping there, running a bunch of calls for free. So when somebody said, hey, you're 21, here's a couple dollars an hour now, sign me up. I'm getting paid. Yesterday I got it for free. Today I'm doing it for money. All right? So we didn't talk about patient care reports, or the importance of them. You need to take it seriously. You need to make it a priority. It should be as accurate as possible and complete as possible. And don't ever embellish on it. There's no need to embellish. That just gets crazy silly. So you don't want to be doing that. All right. This is key too. It's not only a reflection on you, it's a reflection on your team and your organization. All right? So if we run a call together and I write a crap chart and it gets called on the carpet for whatever, is he in trouble too? Absolutely he is. So it makes sense for you to at least look at the trip sheets that your partners are writing. Not just assume they know what they're doing, not just assume they're putting in the right stuff. You should, if you're smart about it, you should be looking at what your partner's writing on their trip sheets. Okay? It reflects on the organization. If you write crap charts, you get crap claims submitted. It means you get crap money, which means you get crap equipment, crap wages. Okay? So it's a direct reflection. When I came to Cranberry in 2011, they had gone 5 years without a pay raise. All right? They were running trucks down to the steel threads. All right? Because they didn't have any money. So what did we do? We changed their mentality about it. They got buy-in. I beat it in their heads about why it was important. What did we do? We turned the organization around. We bought brand new ambulances. We got brand new heart monitors. They got better wages. All right? So it can happen. Everybody talks about, it sucks because it doesn't pay crap. Well, the only reason it doesn't pay crap is because services can't bill because people don't write good charts. If you're writing good charts, the only reason you wouldn't be making money is if you have a bad payer population, and there isn't anything you can do about that. Those places exist all over the country. So yeah, there are some people who have a legitimate, hey, we don't have any money. But the rest of us, if you've got a good payer mix, you just need to write good charts so you can submit good claims so you can get paid for what you do. All right, you should know what's in the PCR, even if you didn't write it, like we talked about. No spelling errors, right? You want to be professional, look professional, sound professional. Use proper references. What do we mean by that? Don't use off-the-wall abbreviations. You should have like a master abbreviation list of what you guys use. You don't want to be using things that people don't understand. All right, no opinions. Keep those to yourselves. It should be accurate and detailed. And again, you need to take that responsibility very, very seriously. Because at some point, you may have to go back and justify what you did. And if you can't justify it, or if the billing company can't decipher it, we could have issues. All right, addendums. What do we mean by addendums? Does anybody know?
So we have to redo them, or we get
No. I'm glad you said that. That absolutely is not what that means. Okay? An addendum is not a redo. Once the chart is locked, it is locked. We cannot go back and fix it. All right? If there are things that are missing, or if there are things that need to be placed in it, we then add an addendum. We should never, ever, 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 ever be opening charts and messing with them. Make sense? All right? So if you took the patient to Maine, but they really were supposed to go to General, you just add an addendum and say, whoops, I screwed that up, it was actually this. You don't go back in and fix it. Once it's closed, it's closed. Okay? And the reason is, that seems harmless, right? I screwed it up, I fixed it. And in theory, it is harmless. But what if it's not? What if you went back and, well, I got away with that, so what if I just change the vital signs a little bit? Or what if I just tweak this a little bit? Understand why we add an addendum now? So we don't ever want to go back and fix things within the chart. And those folks that are adding the addendum should be the report author only. However, partners should still say, hey, I add, you forgot to do that, I'll add the addendum. Okay, whatever. So you should make sure that you have the addendum added, and you should make sure that you're both on the same page with what it is you're putting in there. You got a lot of these people? Either as customers or on your staff? You're not allowed to answer that. Don't shout out names, please. We're not calling out anybody. Alright. Little test. Here's your first test. That was your first test, actually. Here's your second test. Ready, go. 2, 1. What was the name of the pilot?
I was like, no,
There's two dogs in the
No,
cat.
it's,
It's us. It says you
I
are.
am the pilot.
Right.
Ah.
You're the pilot, right? Okay? So if you can't remember that after 20 seconds, how can you remember what you did 3 years ago on a call in the middle of the night, right? You're the pilot. So the patient care report, it is a legal document, all right? It does go with the patient through their entire medical record. It is able to be subpoenaed. Everything that's attached with it is also able to be subpoenaed. So if you do special reports that revolve around that, if you have other documentation, if an attorney comes in or a messenger comes in with a subpoena and says, hey, I need this chart from, January of last year for the crash here, here, and here, we got to give them everything.
And it does happen, and that's why I tell you guys don't throw anything away. Submit everything that you get.
Yep. Because even if you're like, oh, I forgot or I missed it, just that one time is enough to say, well, then if you forgot it that one time, how do I know you did it? But I only did it one time. It's like being pregnant. You're either pregnant or you're not. You're not a little bit pregnant, right? You either did it or you didn't do it. All right?
Sorry.
So,
Some people can be more pregnant than others, but
right, but you're either are or you're not. You're either is or you ain't. There's no, right? So it is a permanent record. You need to think about that. It's a great tool for an auxiliary memory tool. I just had a guy last month have to go to court on a crash from 2 years ago, and he's my guy that writes novels, right? Like, he's a great clinician, but he's an even better storyteller. So what would take me, even as a guy who's not on the ambulance that often, 25 minutes to write, it takes him 2 hours, all right? So when he got a subpoena, he was like, oh my God, what am I going to do? I'm like, whoa, whoa, whoa. Like, you're the guy who we want to be called to court. Like, you're going to have everything in that chart. It's okay. It'd be this guy over here. I'd be like, oh God, no. All right? So you do need that as an auxiliary memory tool. And again, it paints the picture for everybody else that wasn't there. The attorneys who weren't there, the billing people who weren't there, your boss who wasn't there. One of the things as an EMS director I get called on a lot for complaints. First one is what? What took you so long? Where the hell were you? The second one is usually about the bill, right? But I can go back to that first one and say what took us so long if in the first line of their activity log they would say responded to incident location from blank. That's all I'd have to do, right? Then I wouldn't have to track them down, find out why it took them so long, ask them where they responded from. So about 6 months ago I got tired of getting those phone calls. I said, look, if you just make that first line, responded immediately to incident blank from the station, the hospital, this post, then I know. When the people call to complain about what took you so long, I can go, well, it was 5:30 Thursday afternoon, traffic was terrible, and they had 12 miles to go to get there. But if that's not on there, then I got to go back through, or I got to find them, or I got to go, I don't know, man, I got to get back to you. Right? So just little things like that can help paint a picture. It can make, some folks' lives a lot easier. So let's look at an example. ALS transport from the community hospital to tertiary hospital. Is it an emergency? We don't really know. What's the chief complaint? Rule out MI. Bed confined, no information in the PCR. But on the PCS it says failed stress test. Here's the chart that accompanies that. Anybody see problems?
If anybody thinks that's okay, get the hell out of here now.
Oh, no, those are the ones who want
way
to
too
stay.
short. It's really vague.
No, bye-bye.
It's not descriptive, it's extremely vague. Do we really want them walking to the stretcher? Maybe not, right? I mean, what was the assessment during the trip? What were the vitals, okay? Now, let's look at this. Here's same scenario, a little bit more information, right? It is non-emergency, so we do know that. Chief complaint is chest pain. They're not bed confined. Is that an issue for us? If they're not bed confined, but we're taking them by stretcher?
Mm-hmm.
Not in this case, because why?
Oh,
Requires cardiac monitoring, and essentially he's going
I
for
didn't
what?
get that far.
He's going for a higher level of care. If they're going from a community hospital to tertiary hospital, it's usually for an upgrade in care. All right? But because they require continuous monitoring, they can't get that in their Jetta or Saab or Chevy. They need to have an ambulance for that, okay? What do you think about this? Does that read a lot better? Does that paint a much better picture of what's going on? Even the EMTs in the room, can you see how the detail is important for those paramedics that are in the room? This is what we have to write all the time, right? We've got to write why we did this, why it was like that, why this was done.
Also, we've been adding to them recently about, we've been stressing to them, telling them to do patient's history in there.
Mhm.
If they've got a history of MI, if they got a history of heart trouble, whatever.
And there's really no physical exam in there either, so you don't know what the patient
No.
looks like.
Correct. And you're dispatched to the medical center to transport the patient, but it doesn't really say why they came in. So there are things that we could add to this, right?
Oh, yeah.
The whole idea is just to say, between that and that,
Big difference.
big difference, right? Again, we talk about, we're painting the picture. So that gentleman or that lady in Pittsburgh in the cubicle reads that and goes, I don't know, right? Versus this, whoops, much different, right? Can spell it out, can almost visualize it, right? Now there are a couple things in here, like I said, you might want to add, they came in to the medical center complaining of chest pain, all right, because that's important. Why did they present to the system? That transferred to bed upon arrival. What I've been telling folks, and I think it's important, is what bed, all right? Transferred to the emergency department bed 4, or transported to the cath lab on the 3rd floor, or transported as a direct admit to room 6780 on the 6th floor. All right? Why is that important? Well, it's important because, let's say they're going to the emergency room, and we don't delineate or describe which bed we put them in, right? Transferred to, XYZ Hospital's ER. Care transferred and we left.
Even if that's recorded elsewhere in the PCR, you're like in a different tab.
Well, if it's in the PCR, that's fine. But, if it's not, or if you have to have it in this narrative, the reason it's important is because, as a paramedic, let's run this scenario. Who are the paramedics in the room? So, as a paramedic, if you bring in an intubated patient to the emergency department, walk me through how you transfer that care. Paramedics, how do you transfer that care?
Basically, whenever we walk in, we get surrounded by nurses usually,
Mm-hmm.
and I ask to make sure we have an RT available.
Mm-hmm.
After the IVs and the monitor and the receiving respiratory person's all ready to go, they coordinate the transfer over, we transfer over, and they decide whether or not they're going to transfer the tubing before we transfer or transfer the tubing after the transfer.
Okay.
And then when we successfully got them on the bed and we've checked to make sure that their tube hasn't been messed with or anything like that,
Well, how do you know it's been messed with?
RT checks the breath sounds and
Okay, but when? At this point, where's the patient now?
on their bed.
On their bed, right? So, where I'm going with this is, they should be checking it while they're on your bed. Because once they move to their bed, they can say whatever they want. Alright? If you transfer that care and walk out,
Val.
and now the tube gets full,
Last run I had scheduled today.
where's your validity that it was still good, right? So, when I bring a patient in that's intubated, and the nurses go, okay, well, stop. Somebody's going to listen and confirm that tube. Because once it's moved to that bed, it dissolves me of any problems. So I'll even have the physician come over and go, yep, it's good. Okay, now you move the patient. And once they get moved to that bed, I can run out of that room, right? I mean, I got to give a report, but the problem is, there are too many scenarios where things go amok, and as one or two people, or maybe he goes out to make the stretcher, now I'm the only EMS person in there. I turn to leave, and there are 3 or 4 people muddling around this patient, and snap, out comes the IV. How easy is them to go, oh look, the medic didn't get the line. Oh, no, that's not what happened. But it's my word against the 4 of them. See where I'm going with this? And nobody wants that to be an issue. But if you detail in your report, transfer to ER bed 4, then we know that patient had this problem, went to that bed. There's no well, where did you put that patient? Well, who did it? Who was the last person to touch him? Right? So, again, I'm not the end-all be-all of documentation gurus, but the last lines of my trip sheet, right? Arrived at the emergency department room, whatever. Patient, presented to that ER, awake, alert, oriented, airway intact, IV free of signs of infiltration. Last known breath sounds were this, whatever. They checked it, and then they moved it over. Whatever the hell they do once they're on their bed, I don't care. But I'll be damned if I'm going to let them jam me up on something that they do. So just think about that when you're transferring care. Nobody means to do it. It's not a malicious act. But if it means them getting in trouble or having to do more work or them throwing you under the bus, what do you think they're going to do? And I'm married to a nurse. Okay? So, yeah. So just think about that. You want to try and be a little bit, if you can be more descriptive, then do it. Oops. Alright. So, in the patient care report, it should talk about why are they accessing the health system in the first place. Like I said, to that guy, why did he even come in? Why is he going from point A to point B? He's going for a cardiac cath. It can't be done at that local facility. What's happening that's going to that destination facility? That's what they're doing. Could not be done. Level of care administered during the transport. We did do care during transport, right? We applied and monitored cardiac, hemodynamic stable cardiac stuff. Why are they going by ambulance? Well, because like I said, there's not a LifePak or a Zoll or a Philips in their Jetta. Alright, and what is the condition of the patient? Alright, now, a little bit different when we're going to 911 calls, okay? If we look at patient care reports from a 911 or a scene perspective, we want to talk about the call source. Those 911 calls that you guys go on, how are they dispatched? Through a county 911 system or, okay. So at that county 911 system, do you know if they do EMD? Do they do priority medical dispatching?
Cass does. Yeah, Cass County and Rensselaer both do EMD.
Okay. Do you know which system they use?
I do not, but I think most of them around here use either the APCO system or
ProQA, Clausen.
No, not ProQA. PowerPhone.
Okay.
Yeah.
So I'm happy that you said APCO. So where I hail in western Pennsylvania, Allegheny County is where Pittsburgh, the city of Pittsburgh proper lies. Allegheny County does the 911 dispatching for the entire county and for the city of Pittsburgh. They are currently in the process of moving from a Clausen type EMD to APCO.
Mm-hmm.
The problem with that is APCO codes a lot more calls at a lower BLS level. If they do that and they approve that and it goes through, those EMS services will lose tons of money because they won't be able to bill for ALS assessments on calls that are dispatched as BLS. So that's huge, right? So how we receive the call is important, right? If it's dispatched as toe pain and we send an ALS truck because that's who's close, and we get there and it's toe pain, are we doing an ALS assessment? We're not, okay? Even if we did it, we're not going to get paid for it, all right? Now, if we get dispatched for chest pain and we send an ALS unit out there and we do an ALS assessment, but it ends up being toe pain instead of chest pain, that's okay because we utilize the skills of the ALS provider to rule out anything with what we were dispatched. Does that make sense?
We had one, speaking of toe pain, we had one of those calls, I don't know, 3 or 4 weeks ago, and this patient had dropped a can on her toe. And it said, in the the notes, it said, the caretaker stated, if they would, and so it didn't, it got kicked back, it couldn't get paid. There was no reason. If the person doing that narrative would have stated, why did that patient have a caretaker?
Right.
That would have been a big difference.
Right. If they weren't able to do ADLs or activities of daily living and they needed somebody to help them, that could have been a possibility to get paid, absolutely. Alright, so we talk about how's the call received or how's it dispatched. What's the response level? How many times are we going lights and sirens? This was a big discussion when I was up in Merrillville yesterday. If you're running lights and sirens to everything, you better have a damn good reason in 2017. Okay? If you have priority medical dispatching, if you're going to a nursing or medical facility, you really, really better have a damn good reason. Okay? What would be the purpose of running lights and sirens to, let's say, a sniff for somebody having trouble breathing? What's already there? Sniff is skilled nursing facility. Nurses, doctors, oxygen, medicines, right?
Good
that
point,
already
but
exists in the 4 walls of that facility. What are we being requested to do? What did I say we do and get paid for? Transport, right? We are going to treat the patient, right? But before we get there, could they not start some of that stuff? No, they usually don't because they're not really good at it.
Not some of
But
the facilities we deal with.
if you go blowing down the road lights and sirens and you kill my family, I'm going to own you. Because that's a nursing facility that has doctors and nurses and medicines and IVs and you don't need to be doing that. Unless protocol or something dictates. Okay? You're always going to fall back to that. But if you don't have a response level protocol, I would suggest you look into that and decide, should it be lights and sirens? what they were saying up there was some of their municipal contracts state they have to be lights and sirens. Or then somebody else said, well, no, it just says 6 minutes. Okay, well, if I'm 2 minutes away, does it really matter if I'm using lights and sirens to get there? I'm going to be there within that 6 minutes, you know? But once you turn those lights and sirens on, you open yourself and the organization up for so much litigation, all right? And it might seem like I'm on a soapbox, but my organization, which I was not affiliated with at all until I became the director, in 2007, on an inter-facility transport at 12:30 in the morning, thought it was good to turn the lights and sirens on and blow through an intersection where they hit a car and killed 2 guys. With a stable cardiac patient in the back of the ambulance. No reason to be running lights. No reason to be going like that. Just to move from here to there. Killed 2 people. Now, the backstory on all that is, of course, she was under the influence because she was drinking 12 hours before her shift. And like there was a lot more to it, but the root of it is going from community hospital to other hospital with a stable patient running lights and sirens at 12:30 in the morning. What is that? That's crazy. You know, we get sued and we open ourselves up for liability because we do not smart things. So if you don't have response level protocols, I would look at that and try and figure out when it's appropriate, when it's not appropriate. And as you begin to maybe explore municipal contracts or different things, it's okay if your 6-minute response time is what it's supposed to be. And if you need lights to adhere to that, then okay. But if you don't, why are you turning them on? All right. What's the patient's condition upon arrival? Note any delays in gaining access to the patient. This is big because how many times do you pull up, let's say you're going to an office building for a patient with chest pain. Put the ambulance in park, you call out on scene or push a button. Take all your stuff out of the ambulance, go through the doors, in the elevator, up the elevator, down the hallway, down the... What do you think the time difference is between when you put the ambulance in park and when you actually got to the patient?
5 minutes.
Right. Maybe easy 5 minutes. Maybe closer to 7, 8, 10 minutes. But what time do you put on your chart for on scene? The time you called out, right? So you might want to think about when should we be acknowledging our time on scene? Is it when we're at the patient's side? Again, I don't know. I'm not here to tell you how to do your operational stuff, but like those are things you need to think about. Because as you call on scene or as you punch that MODAT that says you're out, and now by the time you get up to that patient, things got worse. Now you got a discrepancy, right? Because you're like, well, I was on scene at 14:38, but I didn't make patient contact till 14:45. Well, what the hell were you doing for 7 minutes? Oh, we had to wait for the elevator, had to fold up the stretcher, and we dropped the monitor. You know what I mean? Like that stuff happens.
Did you get my message?
So like those are things you got to think about. And again, what drives that? What makes the most sense? What makes what's best practices? Again, I can't tell you how to do that, but you just want to think about some of those things. Services rendered. This is important, especially from an ALS perspective. Okay, so we did an ALS assessment. We provide an intervention. We then should reassess to see how well that intervention was received. Okay, patient falls and breaks their leg. They're in 10 out of 10 pain. We assess it. We start an IV. We give pain management. We should then reassess it to see where that 10 out of 10 pain is. If it's still 10 out of 10, which it could be, then we're going to continue to manage it. If it's now 2 out of 10, yay, we did a good job. Okay? But we should document assessments, interventions, and response to interventions. And pain right now is the big thing. Medicare is really looking at, well, they said they had pain. Did you do anything to help them? Or did you just bounce them down the steps and take them to the hospital without taking care of them? Now, it might be even BLS, right? It might just be you put a good splint on it and gave them a little bit of oxygen and they feel good. But you need to document it as we assessed it, we intervened, we reassessed it. All right, and then you need to follow your regional protocols. Trauma alert, stroke alert, cardiac alert, sepsis alert, butt hurt alert. There's so many different ones out there anymore. So, all right. I would imagine this is where most of you live, right? Interfacility stuff. This is also where your organization has the biggest liability. All right, because this is where things are kind of gray. Not everything is real cut and dry. So what do we need to see in the patient care report? It needs to have the reason for hospitalization, the reason for the encounter, why they're being transferred, what their condition is at the time of transfer, the reason for the ambulance versus any other means. If you look at care and transport, time sensitive, or bed confined, stretcher bound, or unable to ambulate, if a patient doesn't meet one of those criteria, they should not be on your stretcher. Okay? Because the only reason you need an ambulance is because you're going to provide care while you're in transit, it's a time-sensitive thing, or they are bed confined, stretcher bound, or unable to ambulate.
And when you say care and or care and transport, you're also referring to maintenance of whatever.
Correct. Right. Yeah. If they have an IV line, and it's just running at a KVO or keep vein open rate, that has to be managed. Right. It has to be whatever. Okay. Oxygen is for the BLS folks in the room. Oxygen. This is again where this is gray. If they're already on oxygen and they self-medicate it and self-administer it and they can do it, that's not just good enough to have an ambulance, because they already know how to manage that oxygen, right? So they're not really getting care and transport, unless it's different, right? If they're on 2 liters, but now they're breathing in such that they need something different, okay, as long as we document it, then we can maybe do that. But if they're on 2 liters for forever, and they're still on 2 liters, and they need to go somewhere, and they can walk from here to there, and they can do all this other kind of stuff, and they're not bed confined, should we put those people in an ambulance? Probably not.
I back you up to reason for transfer.
Yes.
One of my biggest pet peeves, and I've been accused of being aggressive with nurses, when they fill out our medical necessity and I put on there the diagnosis. And the diagnosis is in their medical history. It leads one to believe that that it's not new.
Right.
So, when I ask for what's the reason going to the hospital, they say, higher level of care.
Right.
Recently, Sally's informed us the higher level of care is not permissible.
So
it has to have a backup.
So here's where it gets really even more skewed, right? There are 2 things when you're doing interfacility transports. Why do they need to go from A to B? That's the first thing. Why do they need an ambulance to go from A to B? There might be a perfectly legitimate reason why they need to leave A and go to B, but there may not be a perfectly legitimate reason why they need an ambulance to do that. Okay? It's not EMS's problem to move patients who don't belong in an ambulance. It's not. Right? It's the hospital's problem. Now, we are customers of the hospital, we service the hospital, right? But you're not going to put yourself into liability by taking those transports and falsely, filing false claims just because you want to service the hospital. Like, nobody's going to do that. Yes, sir.
I've been just straight up told by a nurse that the only reason they call for an ambulance is they know our wheelchair vans aren't available at a certain time and they need the patient discharged.
Right.
What do we do in those situations?
Do they need it for care and transport? Do they need it because it's time sensitive? Do they need it because they're bed confined, stretcher bound, unable to ambulate?
No.
Peace out.
Aha.
But you still do the run, and you do it as it was dispatched, and I will
Right.
figure that out.
Right. Operationally, you can do it however you want. I'm telling you, from a billing standpoint, you can't bill that.
Right.
Exactly.
That's
So
what
if
we're-
operationally you want to spend the money and the gas and the resources to do that in an ambulance, I'm not here to tell you yes or no.
No,
Yes,
we were actually, that was a perfect impromptu opportunity. We were setting Sally and dispatch up with that question.
Right.
Because from our perspective, we can't say, no, we can't do this one.
So what I would do before that even happens, how do you guys get those phone calls? How do you get those requests for service?
Dispatch.
So dispatch should say, does the patient need an ambulance?
Well, the other issue we have too a lot of times is when they talk to dispatch, they'll tell our dispatch they're unable to ambulate or they're bed confined, this and that, and then
So
we
why?
get
So
there.
it's okay for dispatch to go, okay, why can't she ambulate?
We get
Why
them
can't she
walking
this?
around the room.
They'll tell them that information and
Right.
dispatch will try to get it from them, they won't give it to dispatch and then we get there and it's a
So-
completely different
So
story
what you
than
need to
they
do
said.
is, as the frontline folks, you need to tell your administrator to go have a conversation with their administrators to say, look, we want to service you, but we want to service you in the most appropriate method. It doesn't make sense for us to take 2 people in an ambulance out of service to go do that transport that we could have sent 1 person, right, in a wheelchair van to go do. Or we could have helped you mitigate an Uber or a taxi or something of that nature. As healthcare is changing, EMS and the reasons to do this become more and more strict. It doesn't make sense. And hospitals don't care, right? They want people the hell out of there. They want the bed available. They want less work to do. whatever. They don't give shits about us, right? But that doesn't mean that we should just eat it. That means that we should be doing a little bit better job at screening those calls, understanding, hey, why do they need an ambulance? Way long time ago in my former life, I worked at a dispatch center that was actually in the hospital. And every day they'd send down probably 40 discharges. And of those 40, they'd probably code 30 of them as an ambulance. How many of them do you think really went out by ambulance? Maybe 5? Because once it would come down, we'd go, we call up to the floor and go, hey, can I talk to the nurse? Why does this patient need an ambulance? Well, because they've got dementia. Okay, are they sitting in a chair or able to ambulate on their own? Yep, that's not an ambulance. We'll get you a wheelchair when one becomes available. Click.
Dementia is you can go wheelchair?
If they're able to support, if they're not bed confined, stretcher bound, or unable to ambulate.
Can I
What?
cut off?
Dude, we
let
just
me-
took
let
a
me
run the
ask
other
this
day.
question real fast, and
Go
I'm
ahead.
gonna cut this in half. Sally, are we gonna have a how do you want us to respond to this situation meeting outside of this meeting? Or do you wanna try to answer these questions now?
We can, if you mind,
No, this is completely.
So,
Wait, you're talking about yesterday?
GCS,
anyway, yes.
this is where we've had this conversation, I've had it with someone. GCS of 12 is fine if that's their normal. If the patient's alert and oriented times 2, we take them by ambulance. That's what we do. The GCS and the A&O is different.
So, and we're going to get into that here in a little bit. So, again, I'm not trying to have a coup against her. I'm not trying to call her
we're
out.
not either.
What I'm trying to tell you is from the billing side of things, if the patients don't meet one of those 3 things, they should go by other means. How you do that operationally, how she tells you, I don't care that they're walking, you go in an ambulance, that's not Jeff Kelly, that's your boss. Now, I can tell you she's probably not billing Medicare for ambulance transports on that. Please say no, please say no, please say no. Please say no.
No.
Right, okay? Because she's smarter than that, and she knows that because they don't meet one of those, and you just took them by a stretcher because that's what you had available, all right? If she is, I'm sure when I'm gone, she's not going to do that anymore. But, all right, but they've got to meet that requirement. If they don't meet that requirement, then they shouldn't be on a stretcher in an ambulance.
But Sally, basically, we're not going to be making these decisions. Those are kind of decisions that you guys make.
Yes.
Yeah, you shouldn't be making.
Well, it's like we arrive on the scene and our non-ambulatory demented patients doing cartwheels down the hallway and Einstein's mathematician.
So-
And remembers exactly how long
Right.
they've been in the hospital.
Yeah, we go ahead and do the run. Now, the question I would like, because we had one yesterday that was totally questionable.
Yeah.
Do you want us to carry around a pack of sticky notes? Sticky. Not quite sure this is gonna fly. Because the medical necessity said,
Well, so yes, sir. We just had a patient that had a feeding tube in his nose and it got ripped out of the facility, and so they took him back to the hospital and had the tube put back in his nose. And we get there, and I don't know what they told the dispatch, but we get there and they're just like, "Oh, medical attendance required." And I'm
Why?
like-
If
I'm
you
like-
can
I
ask
said,
why,
I
there's
said,
always a why. If you can ask a why, ask it.
yeah, they're just like, "Oh, well, he just had this put in."
You don't ever, and she doesn't, I don't mean to speak on your behalf, but she doesn't ever want you to be confrontational. I don't ever want my staff to be confrontational.
No.
I do want them to ask why, though. And I do want them to go and be a little bit free thinking, like, this doesn't make any sense. And here's where you get bound up, and this is, again, it's not a shot at you. If you're doing that stuff by ambulance, the hospitals will come to expect it. And so if the dispatch says, hey, it's an ambulance trip, and you get there in an ambulance and it isn't, maybe you change what you do and you call back and go, do we have a wheelchair van available? No, we want about 35 minutes. Okay. Go out to the staff and say, look, this is an ambulance appropriate. We're going to get a wheelchair van here for you as quick as we can. Okay? Now, they might not like that the first couple times because they just want the patient moved, right?
I know.
But they have to change their mentality. They have to get out of, what they think is they call this number, they get you send an ambulance, and that's just what you take for everybody. What do we know to be the case? That's not the case, right? We know that not everybody needs an ambulance. It's okay for your administrators to instruct and educate their administrators, to instruct and educate their frontline staff on what the hell's supposed to be going on. Just like we're instructing you guys. Okay? Yeah.
so what are we supposed to do in that case? Go ahead and take the medical necessity and...
That's all operational stuff. You're going to answer her on that.
Feel free to question the nurse that's sending the patient, and if they don't know, you are responsible for that patient. Ask for their chart. Find whys. Find the whys. There's always whys.
So
Good.
I noticed a lot of our runs will say like oxygen management, things like that. We get there, they're like, oh yeah, they haven't been on oxygen for like 8 hours, but they
So-
might need it.
So that's right. So, live in my world for a minute. So we have a small community hospital that we service. About a third of what we do total is all of this stuff moving patients out of that hospital. So we get a call, hey, you need to come take this patient down to the other hospital. Is it ALS? Yeah, it's ALS. Patient's on a monitor. We stroll up with our stretcher and our monitor, and we walk in, and the patient's walking around the room, not on a monitor, not going to a monitored bed. The hell do they need a monitor for in the 20-minute transport? Right? Now, if they're going to a monitored bed, that's a little bit different. Okay, we can do that. But they're not on a monitor in your ER, and they're not going to a monitored bed. Why do they need a monitor on the transport? Nobody can tell me different. Guess what? They're not getting monitored. Which is slicing my own throat, right? Because I could bill more, and I could make more money, but it's not right. It's not what's appropriate. You know? So yeah, it is a business, but there's also a little bit of us that says, like, this isn't right. Right? So I have no problem. My staff says, hey, Jeff, this is not ALS. All right, then come back. Now again, we're close, and I'm going to send a BLS truck. And then next week I'll meet with their administration and say, you don't just throw them on a stretcher with an ambulance and a monitor because that's what you think. Like, we can't do that. We can't send resources like that for patients who don't need it. So to your oxygen question, they haven't been on oxygen in 8 hours. Even if it's a 30-minute transport, like what would be the reason that they would need the oxygen? And if they need it, were they already on it? Again, we talked about, can they self-administer? You know, oh yeah, they can. Okay, then give them their own little tank, jam a thing in their nose, and put them in a car. Like, this is, we as a society are paying for misuse of the healthcare system, right? People that work in the healthcare system don't even get that. You know, my wife as a nurse doesn't get it. I gotta smack her. You know, no, you don't do that. Like, you know, don't send people off your floor who don't meet medical criteria. Period. There are other more appropriate means to move patients than stretchers. But that's the easiest way. That's a cop-out. That's a cop-out. And we, as EMS, we've fallen into it. Because we're like, oh, it's runs, it's runs, it's runs, it's runs. We used to be able to do it, get money, get paid for it. Now we do it, try to get paid for it, get audited, it's illegal, we shut down.
What about PRN pain meds?
If they've had medication in a certain period of time or that requires them, that they might have, that they need to be monitored, that absolutely should go by stretcher. That's care and transport. Right? So, hey, we gave them fentanyl 30 minutes ago. You know, well, fentanyl's probably bad. They gave morphine 30 minutes ago. You know what the half-life of that medication is. They should be monitored. Their breathing status should be monitored. That's care and transport.
Ours is still on it.
It's a lot. I mean, whatever.
They gave it 5 minutes ago.
Yep. Right. That's care and transport. All right. Did we beat that up enough? Okay.
Yeah.
Good. I mean, is this good? Is this what you're hoping for? Is like interaction on that
There's
transfer?
still a lot of gray area. But
It is gray. I'm not here to make it black and white on, and I'm sorry, but it is gray. All right. The other area where you get dinged for a lot of liability is right here. All right. What I try to tell patients or tell people is, if you remember way back to like probably almost the first day of EMT class, and then probably the first day of paramedic class, you learned this little thing called legal, right? EMS legal. What's the first thing you have to have before you can even engage a patient? What's that little word? Starts with O and ends in consent. Consent, right? So if you go back to our hellacious big crash, right? If I walk up and I say, "Are you injured? Do you wish to be assessed by EMS?" He can only answer that 2 ways, right? If he says yes, what do I do? Assess him. If he says no, what did he just do? Did not give consent. Are you injured? Do you wish to be assessed by EMS? Yes? Okay. We're going to stop here and do this. No? If he doesn't give consent, he doesn't give consent, she doesn't give consent, I can't touch them. Now that's kind of black and white, right? But it's the same way we walk in on an emergency call. Is it alright if I take your blood pressure? Is it okay if we're going to put a heart monitor on you so we can take a look at your heart? Is that okay? Like, you have to get consent for that. I just can't walk up and go, that's assault. I can't touch him without his consent. Okay? I know that seems very elementary and very black and white, but it is black and white. Right? Yes, sir.
And with altered mental status patients, does that fall under implied consent?
Only if you can prove that they're altered.
Is the diagnosis of Alzheimer's type dementia with a patient who's alert and oriented times 5?
Only if you can prove it at the time of the condition. Right? So I have dementia patients who couldn't spell CPR, but in the 20 minutes I had them in an ambulance, knew who they were, where they were, what they were going for. You know what I did? Signed my paper. Because at the time I had them, I documented that there was no reason they couldn't sign. They have dementia. Okay. Not everybody has dementia 24/7, 365. All right, so there are, again, I know you're looking for black and white, but it's not. All right, so the coding process. This is where those coders take what we do from a clinical perspective and turn it into billing perspectives. Take the clinical ease and turn it into billing ease, if you will. It's not always an exact translation, and it's not an exact science. They look at response types, service levels, and diagnosis. Now, as EMS providers, we're not allowed to diagnose, but the picture that we paint should fit into a diagnosis code. All right? How many of you have heard of ICD-10? What is it?
Coding?
It's coding, right? So here are some examples of what that coding looks like.
What?
Right.
Is this real?
Struck by it.
They are.
They are.
Coders have lots of choices. It can be very challenging, right? Here in Lafayette, I'm not sure that we would be struck by an orca, but you never know.
Is there a separate code for a secondary encounter? Is my curiosity with the orca.
Like if you're struck by an orca,
If you
then
need,
get
if
bit
you
by
need
a shark?
that. Oh wait, it gets better.
Accident on knitting.
Remember these
For
for when you get
second
your
gen.
medical code or medical assistant, Michelle.
What?
Yeah,
And
no.
so
What
this
do you
kind of
assess
stuff
these on the
affects our reimbursement. The coding process, if they can't accurately code what you've put in your stuff, then we can't get the claim submitted. Or we can get it submitted, but usually we'll get kicked back. Alright? So in that coding process, medical necessity is always the basic underlying. Alright, we need to look at each one of those levels, BLS, ambulance, ALS versus ALS2 versus SCT. Are you guys doing specialty care transports here? Okay. Are you certified or are your paramedics certified? You have documentation that shows if that paramedic rode that call that they have the certification to do that. Do you have all that? Okay, good. And it's different everywhere. In Pennsylvania, they've just recently come out with we can get SCT accredited, if you will. We would have to send our folks through a certain amount of training and all that kind of stuff. For less than 5 calls a year, I'm not doing that.
Just so you guys know, the SCT is the same as our CCTs.
There you go. And you guys aren't using any rotor wing or fixed wing stuff, right?
They are, but that's not what everybody knows them as.
So, on emergencies, coding is pretty straightforward, right? We have an immediate response. That means the little thing went beep, 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 or somebody yelled down to go here, or we got told to go somewhere. So we didn't, finish eating our sandwich or finish washing the truck. We dropped what we were doing and we responded immediately. All right? That's kind of that's sort of straightforward. All right? But it's important because there is a little bit of room for interpretation from that. How quick did you respond and that sort of thing. All right? Advanced life support has to have an ALS assessment and at least one ALS intervention. Now, remember we talk about if you've seen one EMS agency, you've seen one EMS agency. Well, there are 50 states in the United States, however many EMS agencies per state, right? What is an ALS intervention?
Cardiac monitor.
Okay.
By the state.
Is it right? It's determined by the state. Some places have EMTAs or advanced EMTs or have whatever. So every state is different. And QuickMed does billing for folks all over the country. So their people have to know, well, so the way they group it is they group folks who are there's a Western Pennsylvania pod, there's an Indiana pod, there's a New York pod, because if they try to have one person that has people from all over, they would get confused all the time. Right? So they try to geographically pod them out so that they know, oh, you cover Western Pennsylvania, then everything's the same. You cover Central Ohio, it's all the same. All right? But for an ALS level 1, has to have an ALS assessment, at least one ALS intervention. Advanced life support, though, the assessment performed in an emergency response doesn't necessarily result in the determination that the patient care requires ALS service, right? So we got dispatched as chest pain, we went there, not having chest pain now, actually didn't have chest pain but knows the system, so if I call chest pain, what do? You come quicker. I'm really having a hangnail. And I just need a Band-Aid, okay? So just because you get emergency response and respond immediately for what you believe is an ALS emergency, it's not clearly defined that you can make that happen. And the burden of proof still lies with the ALS provider. Oops. Yeah, we talked about that. So again, whoever does the document or whoever does the assessment needs to be thoroughly documented. We're not telling you can't have an ALS assessment done and BLS ride in. What we're telling you is you can't paint it with a brush and say, well, we do ALS assessments on everybody. Because I'm going to throw that little flag, right? Little BS flag and say, no, you don't. If you do, you're doing something wrong. All right, and be clear about who did the assessment. All right, paramedics in the room. What constitutes an intubation attempt in your world? Don't read into it. When you're documenting, if I have a handle in my hand and I pass it into the mouth and I go, and then I go, oh shit, I didn't get the tube ready. Is that successful times 1?
No.
Why not? I only attempted to place that tube one time.
But he opened the airway once prior to that, to suction and started it.
Right. So again, it's different strokes for different folks and everybody does it differently. But it is important that we document even unsuccessful attempts. What about, I used to work with an old school medic who went, poke, miss, wipe, poke, miss, wipe, poke, oh, I got it, successful times 1. No, first of all, no, you're not. And second, what are you doing? Okay? So we want to make sure that we're documenting any unsuccessful attempts. We want to make sure that we have good documentation as to why. You know, if we're in that airway and we are suction, 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 and we leave the blade in and we just pick up and drop the tube, okay. But every time you take that laryngoscope out of there, that, in theory, that should count as an attempt. Which is why you should have that checklist of what you need for your airway before you get into some of the airway. Alright, we talked about this, SCT, make sure you have the right people on those calls. And the reason for that is not just from a coding perspective, right? You don't want to put somebody, an ALS provider, in a situation where they're not comfortable or they haven't been trained to do it, right? Like the last thing I want to be as a paramedic who doesn't have SCT training is in the back with somebody on 6 drips on a vent trying to manage something, because that's not my world I live in, right? So you want to make sure you don't put them. Remember we talked about those ICD-10 codes? These are all of the codes you have just for a femur fracture. And they have to be that small so we can get them on the screen. I can even barely read them on my computer. What I will tell you though is, alright, down here on the left side, it talks about a non-displaced femoral head of the right femur. So we go to this call, lady has a right femur fracture. We run the call, everything that we document says left, 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 left. We submit the claim and it gets denied. And she goes, what the hell? How does that get denied? You know, we gave pain management, we reassessed, we did all this other kind of stuff, it was great clinical care. Oh, it was the right leg, not the left leg. Right? That seems minute in your world, right? Whatever, right versus left. But what we just did is cost the company possibly $1,000 or more. Because now we have to bill it, we built it, it had to get rejected because we put the wrong side on it. We have to resubmit it, it has to get processed, and now we don't get all of the money because somebody else got to us first, so we only get 1/3 of what we could have gotten. All because you couldn't distinguish between your right and your left. You understand now why this is the responsibility of the frontline providers and why it's so important that you have attention to detail, and why it's okay if you're on your 24th hour, you shouldn't just write garbage, because it affects everything that goes on. If the company doesn't get paid, who doesn't get a paycheck? Y'all.
I know that one.
sure every one of you here would like to make more money.
Jerry Maguire.
Not
Help
me, I
us.
do it for the love of you all.
It's Jerry Maguire, right? Help us, help you.
Exactly.
Help us, as managers, help you. Okay?
I'm gonna
Those are
use
all
that.
the codes for an ICD, or ICD-10 codes for just a femur fracture. Make sure you document. And again, you don't need to know those as providers. If you paint a great picture, that billing person can go, oh, yep, look at that. Boom, right femur fracture. Done.
And
Good.
is there any such, this is gonna sound totally wrong, but is there any such thing as having too much information?
No.
The reason I'm asking that is because it's like, let's go with the fracture kit. A person says, we're being transported because of a fracture kit. I have a tendency to write novels, so I'm being transported for a fracture kit. Actually, that's like you said, with all that additional information. Oh, and by the way, this is
So
the
what
second
what
time
would
this is
cause
happening.
you, as a paramedic, to write all that other fluff?
As well.
Remember, she had
but
3 weeks
how
of
would,
it.
how would you know? How would you know that they have a non-displaced femoral head fracture?
Because I read the paperwork.
Okay, so you could document that, right? Per the accompanying paperwork, patient it's shown on
Okay,
X-ray to
that's
have a
what-
distal femur
perfect.
fracture,
That's what I need.
right?
to
Yeah,
know.
yeah, no, no. You're not surmising it, and you're not saying oh, I saw it with my X-ray eyes. You're saying per the paperwork,
Okay.
patient was diagnosed with a distal femur fracture. Yeah, that's okay.
So that's what I normally do, and actually I didn't have, that was the answer I was looking
Yeah.
for. I just didn't have a clue. And I
Yeah,
asked
what
the
you can't do is you can't make an opinion or you know, employ your, this is what I think. No, you know, it's like ETOH, right? You can't say that they're drunk. You can't. You can say they have findings, right? Bloodshot eyes, slur in their speech, unsteady gait. I asked them and they told me. Like, there's the Holy Grail. Sir, you been drinking tonight? I had about 6 drinks. There you go. Like, I don't have to surmise anything.
Lightweight.
Patient was active, they consumed alcohol? Right. They admitted to it. Right? Now, he might be able to stomach 6 drinks and it not affect him. She might not be able to get through 1. Maybe I have that backwards. Maybe I have that backwards.
Do you see what I work with? Trust me.
But, you know, right? So, I mean, but it's okay. You ask them, hey, have you been drinking tonight? Hey, look, I'm not the police. Like, you're not, you know, yeah, I had 6 beers. Okay. Patient admits to having 6 beers.
As
You're
I've
not-
told many of you, you guys are not the doctors.
Nope.
Put facts down. Do not lie.
Right.
Do
Don't
not assume.
Don't embellish, don't assume, don't give opinions. That's exactly it. All right, medical necessity. Established when the patient's condition is such that any other use of, or any other transportation, method of transportation is contraindicated. Okay? Again, why are they going from point A to point B? Why do they need an ambulance to go from point A to point B? All right, ambulance transport must be medically necessary. Transport must be to obtain Medicare coverage services or to return from such a service.
What if we don't know it's Medicare? That's why we're doing it on all patients?
Correct. Everybody else pretty much follows the Medicare guidelines. Medicare is the end-all, be-all, holy grail of stuff. All right, so defining bed confined, and we sort of beat this up, right? Unable to get out of bed from assistance. This is just one more, you know, thing that we can justify for why they need a stretcher. All right. It has to be the patient's condition at the time we're there. All right, I'll give you the for instance. You're called to the hospital to discharge somebody to a rehab facility who is status post-hip surgery. And you, as you're walking into the room with your stretcher, the patient is sitting in a wheelchair. And right away you go, whoa, 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 sitting in a chair. We're not taking it. Okay? Without even talking to the nurse, without even looking at the paperwork. Right away you're like, ah, we're in a chair, we're not taking you. What you don't know is they're not allowed to sit in that chair for more than 5 minutes. And the only reason they're in it right now is because they had to go to the bathroom. And they had to be assisted into it, wheeled into the bathroom, assisted at the bathroom, assisted back into the chair, and they literally just got wheeled out of the bathroom as you came back out. They can't be at that angle for more than 5 minutes. They need your stretcher, they need to be semi-Fowlers, they need to be in that position. Those are the doctor's orders. But I got some guys that work for me that are like, they know it all. That patient was in a chair. So, they're on total hip precautions. You're taking them 35 minutes down the road. They can't sit in a wheelchair for 35 minutes. Stop thinking you know it all. Talk to somebody, read the paperwork. Don't put those blinders on. Don't think just because you walked in there with a stretcher and they're in a wheelchair that you don't have to take them. Right? She said earlier, it's okay to ask why. You know, don't be confrontational. But, you know, what we do, and again, this is just an operational thing, we don't even talk and go see the patient until we have all of our paperwork together. Until we've engaged the staff to say, hey, this PCS and the chart, they're not matching. The chart doesn't paint any kind of picture of what you put on this PCS. So you need to fix this PCS. Yes, sir.
A lot of the nurses around here try to trap us too, where they, oh yeah, I got the paperwork and everything in the patient's room, and if you come in there, I'll
Can you bring it out
give
here
you
for us?
everything while we're moving them over.
Right.
Oh, yeah.
Because what do they want? What does the hospital staff want?
Get rid of it.
They want you-
Right. They want you gone because if you take that patient now at 15:11, let's say you're supposed to be here at 1500. You're already 10 minutes behind. But I know I won't report that bed open until 1600. So for the next 45 minutes, I don't have to worry about the patient. Right? Again, I live with a nurse. But that's what happens. That's their world. Get them the hell out of there. I don't have to do anything for 45 minutes. Right. Exactly. They killed Kenny.
Right.
But that's it. And I understand and I get what they're trying to do. But you know, if we sort of get sucked into that, then they come to expect it from us. You know, I'm not saying we shouldn't have good on-time performance and do good customer service. We absolutely should, because that's what keeps us in business. But we shouldn't be taking it from them. We're not their floor mats. We're helping them. You know, we got in a discussion up in Myrtleville about EMS bringing patients into the ER and nurses giving EMS units crap. You know what I tell nurses who give me crap? If I don't bring patients here, you don't have a job. Right? That's the reality of it. 55% of the patients that come through the ERs in the Pittsburgh area come from EMS. If EMS doesn't bring the patient to your hospital, you going to continue to have a job? No. Shut up. Right? Before I became a director, I spent 1 year with pre-hospital doing stroke outreach education. So I took one of the world's most renowned neurosurgeons to local EMS agencies, which was a hoot, by the way. The first thing he asked them at 8 o'clock in the morning is, what dictates where you take your stroke patients? And I had no idea what they were going to say, so I just sort of let it go. And they said, literally, they come across the bridge, and they can go a left to Hospital A or a right to Hospital B. If they're crossing that bridge and traffic is bad, on the right side, where do they go? They go to the left. If they go to the left and those people are rude, where do they go for the rest of the day? To the right. I'm completely different. If I take you to the left and you're shitty to me, guess what I'm doing all day to you?
You're bringing more patients.
Bam. Right? But that's just me. Right? Everybody else in the room was like, well, no, I'm not going to subject people to that. I'm going to go here. Eventually, they need to get in the mindset like, it's not a puff your chest out, right? We have to work together, but I'm not anybody's floor mat. And I'm not going to be talked to like that, and you shouldn't be talked to like that. You know, we have to work together. The common goal is move the patient from where they need to be, from where they are to where they need to be. They need us just as much as we need them, right? We need them to make sure all the paperwork's filled out appropriately and everything's together and the patient's ready on time. Because if the patient's not ready on time, what does that do for us? Mucks up our whole day. Right? Boom, 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 boom. If we don't get to the 9 o'clock till 9:15, we're not getting to the 10 o'clock till 10:30. And it just snowballs from there. Right? So you have to sort of give and take. You have to work together. And that is done through good communication. With the staff at their staff, with your management and their management, right? Everybody's on the same page. We just have to sort of need a little coaxing to get there.
What if the medical necessity is filled out by Nurse A?
Mhm.
And she's off the lunch, so Nurse B is there.
So, go ahead.
Well, what I was wondering is, can we make where it says, you know, please delineate why a patient cannot sit in a wheelchair?
Mhm.
Well, our medical necessity says fractured hip, and it doesn't say anything about not sitting in a wheelchair.
Right.
But the transferring nurse said no more than 5 minutes. Is it acceptable to put that in our narrative, even though our medical necessity doesn't say it?
So, I would try and get them to say something about like requires total hip or can't sit longer than 5 minutes.
There's actually a
So really
checkbox
There
on
should
there,
be
isn't
some.
there?
So there should be something in
The
there.
bed confinement?
Now,
No.
the other
In the
thing
big
is
section with all the different
Crash
check marks, one of them has to do with being unable to sit
for
in
prolonged periods
the
of
for
time.
prolonged
Yeah,
periods of
sit
time.
upright for-
So you would prefer that they actually, Nurse B amends Nurse A's papers and put some more information on
I would prefer that whatever paperwork they're going to present me
it?
is a complete and absolute fact of what the patient is. Now, what's different now than, I don't know when they changed it, 10 years ago? Whenever the first, no, it's longer than that, whenever the first medical necessities came out, remember, it was only the physician. So we used to have to track down physicians to get it. Now, anybody that has care of that patient for any time can sign those forms. So that nurse who's covering for the other nurse, it's acceptable
Okay.
for her to do that. It is
But you-
absolutely acceptable.
But
Yep,
you need
but
the
you
medical
want that
necessity
paperwork
say-
to be factual
Specifically.
to what the patient is.
Got it.
Yep, absolutely. That's a good question. Alright. Okay, so isolation. This is again, I wish it was black and white, but it's not. It's gray. Medicare has raised the bar and they require more rationale for this. Patient needs an ambulance because they're MRSA positive. Yeah, 10 years ago. Okay, what are they at the time of condition? What's the condition at the time of transport? Once you have MRSA, once you've been diagnosed with MRSA, at least in the hospital systems in Pittsburgh, you get your own room. No questions asked. Forever. Even if you had MRSA for,
Good to know.
for 2 days, 10 years ago. It's, whoop, Jeff Kelly had MRSA, whoop, private room.
Right.
Now, so nurses will go, oh, I can't get a wheelchair for this guy? I'm going to get him by ambulance. Oh yeah, MRSA. Woo. I'm not MRSA now. Haven't had MRSA in 10 years. I've never had MRSA. But the condition at the time of transport. So that's not legitimate. All right. Now, if they are C. diff positive, they've got seepage, they've got decubiti, they've got open wounds, absolutely. That can be isolation. And we know that there are varying levels of degree of isolation, right? You're certainly not going to put somebody with all that stuff and a fever in a wheelchair van. I hope you're not going to put that person in a wheelchair van, right? You're going to put them in a gown and mask and in your ambulance and make sure everybody's gowned up and everything, okay? But isolation creates a little bit more of a stickier, slipperier slope.
We also need to know, where the wounds are.
Yep.
And actually, we need the stages.
Mhm.
We need details, everything, all the way down.
And that should all be in that medical documentation. Which is why, again, why it's important to maybe change the way you're doing things, to stop at the nurse's station, go through all that. Right?
Hey Dan, you gonna warn the nurses?
Alright, Medicare only covers transports to these places: hospitals, critical access, skilled nursing, homes, dialysis facilities, if and only if we have what? Managers? Pre-authorizations. Okay? You can only do routine chronic transfers for dialysis patients if you've got pre-authorizations. If you let those pre-auths go, don't transport that patient without one. They're only good for so many days or so long, you have to re-up those.
60 days.
Yes. Physician's office is not a covered destination, alright? The physicians should be coming to the patient. They should be coming to the facility, alright? There are some caveats to that. Again, remember, it's not black and white. If it is a specialist, there might be an opportunity. Medicare probably won't cover it, but then what do? We bill the destination, or we bill the facility. Alright?
Are medical arts buildings considered physicians' offices?
Yep.
So again, the medical necessity has to state specifically why they're going.
It does. And so there are times where you guys do those trips, and she's aware of it, and the billing company bills Medicare to get a denial. Or they'll put a modifier on it that gets a denial back, and then we can go after the skilled nursing facility or different places. So it doesn't affect what you do on the front end. It affects on the back end how it is billed. Remember, it's only illegal if you get caught. No. it's only illegal if you're doing it and you get caught, right? We're taking those patients, we're not billing Medicare saying, hey, pay for this, even though we know it's wrong because we took it to a doctor's office. We're saying, hey, Medicare, we did this, and we know it's not covered. Can you please deny this so we can go after the right people to pay for this? That's acceptable. That's okay. Yes, sir.
I've had instance, I've probably transported a certain patient about 3 times that's got hip fracture.
Mhm.
She's bed confined, non-ambulatory by any means, extreme pain even while she's on the cot. But it's been to a medical office building, it's attached to the hospital. Is that is the IU MOB considered a separate facility? She goes there for X-rays and for doctor's follow-ups. Would the kind of limited portability of the equipment be considered valid for Medicare?
So she's stretcher bound, right? So she does meet that criteria. So again, who's going to pay for that is a whole nother arena, right? Your concern like who pays, or are you concerned like should you be taking it?
Well, so Medicare won't cover the transport to those facilities.
Right.
So if she is bed confined, will they still cover it for transport there, or should the physician still be going to the?
So that's where it's gray, right? So she meets bed confinement, but they don't necessarily pay for physician's offices. So how do we, do we get a modifier? Do we bill it with a modifier? Do we bill it to get a rejection so that we can go after whoever else, responsible party, that kind of thing? So there are all those caveats, and that's what all those folks in the billing office take care of. That should not be for you guys to worry about. You're honing in on, is it medically necessary? Do they need to go by ambulance?
And
Outside of
writing it
that, what's that?
down. And writing it down.
Right, and documenting it as such.
And that's why we always tell you guys to make sure that you run the calls as we give them to you.
Yep.
And then make sure that you're doing like he's saying, to put everything in there as truthful, what you got, what you saw, and then it's dealt with on the back end. If it has to be downgraded, it gets downgraded. But, we can always charge less money, we can't charge more. So, when you get there and it's not what they've explained to us on the phone, we're going to leave it as they called for it and then deal with it on the back end.
In
Right.
some cases, if a doctor calls for ALS and that you don't think there's a reason, document everything. Medical history, everything in your narrative, because in some cases, they'll still pay ALS, even though you don't think it was.
Right.
So does the medic still take that call then? It's ALS?
If it's the only time per call on a 911 going into the ER, a paramedic can downgrade it to a BLS. That is the only time anyone can ever downgrade a run.
Does that include if a nursing home calls and we get there and it's
In-houses.
completely different than what they said? And they're going from the nursing home to an ER?
To the ER, then yes, that is going into the ER.
Yeah, he's talking about the in-houses. Those work the same as a regular 911. Though we
But
don't
however-
call in-house 911s anymore, but are in-house 911s. It's the same thing because we ship those all out as ALSs because we don't know. And then once the paramedic assesses and if they decide it can be, and you probably deal with this more in Cass County, all of those go down as an ALS, and then your paramedic decides if it's a downgrade or not.
Let's say that Dana, Kristen goes on an ALS, in-house 911. And they get there and the patient's up walking around. Who needs to assess that patient?
I do.
It's an ALS, the paramedic needs to assess.
It doesn't necessarily mean the paramedic's going to ride it.
Yeah.
No, I
Exactly.
usually, most of them know, I say, are you comfortable?
Right, well what you don't want to get in the habit of as frontline providers, you don't want to get in the habit of how can I downgrade it? Like, you always
Yeah,
want to do
right.
the best care for the patient. But if your services as a paramedic are not needed after you've done the assessment, that's okay. Like, that's why we sent you. We sent you as the paramedic because originally we got a call that said this may be an ALS call. And you got there and said, nope, not so much. Okay, then we'll back it down.
Somebody, if we do a hospital-to-hospital transfer, and we are graced by having one of those nurses that gets it, and literally copies the entire chart for us, and just say that the actual reason and on the medical necessity is upgrade, and that's it, and but you get that the physician requests it.
Because the patient needs to go for a higher level of care, the patient's requesting that?
Actually, the last one I did, and it's all tied with direct hospital to hospital. Since you started having your conversations, about 6 to 8 months ago, I've gotten better at finding out why. But prior to that, it was physician request ALS transfer.
We need
And
to know why
Correct.
they are going to the other facility. Why is that service not available where they're at? Do they need a specialist at the new place?
If it's just for physician preference, insurance companies won't pay for that.
No.
And higher level of care won't fly. You have to actually have.
It has to
why
be a higher
is
level of
it
care.
ALS?
Yeah, of course, it's gonna be higher level of care, but why do they need that higher level of care? Is that not available at point
Right.
A?
So you want the novel.
Right.
But whether you get the novel or not, the medical necessity still needs to have this information actually written on it in point blank terms. So BLS, we're picking up from a nursing home, which is your skilled facility, and
These
they
are
give
drop
you a
offs.
chart.
Don't get confused.
Hold
These
on.
are the only places you can drop off.
Okay,
These are not. You can pick up anywhere.
okay, let's
These are only where Medicare covers transportation to destination.
okay. So we pick up at a nursing home and we take them over here to IU's Med Center, or IU's Medical Office Building, because that's where the new wound care facility is. It is a doctor's office, but they're going for specialty care because that's where the doctor's treatment capabilities are. The medical necessity that we are all looking for, it says wound care, or it says
Wound
DQ.
care and dialysis are different.
Yes.
Okay,
And from a destination perspective, that might be a scenario where we bill Medicare for the referral or the denial, and then we bill the skilled nursing facility for it.
but when we look at the, because I heard you say a few minutes ago that you need to know what was the term you used, grade.
Correct.
that's
Of
not
all
the right
sorts.
word.
Right.
Stage.
Yeah, you need to know stage and grades of all. Right. You need to document all that. So you have to document what the stage of the ulcers were. Right. So if you're picking somebody up from a skilled nursing facility, taking them to wound care, arrived at wherever this nursing facility is, patient has stage 4 ulcers on both buttocks, requiring transportation via ambulance because position of comfort is such that she has to be prone or whatever, and then going to the doctor's office for services that aren't available at the skilled nursing facility, and the doctor needs to see them there. Medicare is probably not going to cover it because it's a doctor's office, but what we'll do is bill it to Medicare, kick it back, bill it to the facility. Because what the facility needs to do is have areas where doctors can come see those patients.
Or if they have Medicaid, depends
Yeah,
on the
Medicaid,
QMB,
right.
Medicaid will,
Yeah.
we GY it to Medicare and then
Right, add a
it's
modifier.
no and send it back to
None of that should be the worry and concern of frontline folks.
Nope.
So again, I don't want you to leave here thinking, this next screen is if you remember nothing else, these are your key documentation points, right? These are the things that will allow you to justify medical necessity in an ambulance, provided you document them appropriately
Remember this picture
at
right here.
the time you saw the patient.
Can we print that out
Hang on
and
a
post
sec.
it somewhere?
I am snapping a picture of it, and I will do so.
Okay? And then, everybody got those?
This is all going to be on Moodle, by the
Couple
way,
more
guys. So.
documentations, here you go, right? So if you say to me, if you said patient can't sign, patient unable to sign because can't use right hand. All right, well, I'm reading your chart and nothing shows me that the patient can't use their right hand. I'm gonna throw that flag and call you on it, right? But if you say patient unable to sign due to being right hand dominant and right hand is contractures from whatever, now I'm going, oh, they can't use their right hand because they got contractures. Okay? Yes?
Is something better than nothing on that, like non-dominant hand, give a scribble?
Yes,
initiative?
and we're going to get to that in just a second. But again, remember, and that's just for like reference, like you should be documenting that stuff. That's what helps get you through it. All right, we're getting there. So demographic information, again, this is important. We don't want to transpose numbers in the Social Security number because then we bill the wrong claim. We don't want to not have a good telephone number because then the billing company can't do follow-up. All right, so it's important that we get good demographic information, attention to detail, carefully recorded.
If
Right.
your paperwork does not match what you have in your dispatch screen from dispatch as far as the spelling goes,
Yep.
fix it.
Yep, we've all discussed that, I think, right?
Fix
Date
it.
of birth, insurance company, right? If you took me on November 30th, my insurance company changed December 1st, so it would have been different on December 2nd. So if that crew took me November 30th, and that crew took me December 2nd, if they are lazy, no offense, and wanted to use their stuff, it's wrong. And now the claim is held up. Yes.
Rehab facilities.
Mhm.
Face sheet has home address, dispatch has dispatch, there's no home address. Which one?
Rehab is short term.
Yep.
Yes.
As far as
you
it's,
know.
it's their home address.
Also a place that most people don't know about, it's called a permanent address,
Yep.
and
That usually has their
Temporary
actual
permanent
address.
Yep. So I was actually going to say that. Address is important, so I don't know how your data dumps here, but like in my system, the 911 stuff can dump directly into my, we use EMS charts, can dump directly into that. So if I'm in town, if somebody lives on Jones Street, but I pick them up at their girlfriend's house on Main Street, the CAD stuff is going to auto-populate this street, Jones Street, but they really live on Main Street. So if I'm lazy, I'm not going to really ask them what their name is. I might not even ask them if this is where they live. But guess what? Now everything that's in there is wrong. Because I was lazy. Because I thought, well, you said you live in town, I picked you up in town, this is obviously where you live, but it isn't. You live over there. And that's the information I need to have. Okay? We have this thing that we can do with the hospitals. I don't know if you have it here. It's called the HL7 feed. Do you guys have HL7? So we take somebody into the emergency room. By the time we leave the hospital, we can get on our computers, we can get to a demographic page, I can hit tab space, and it will auto-populate from the hospital.
they have that up north, it's called Epic up north.
Yes,
We don't
Epic,
have it
same
here.
thing. But that information is just what the hospital is giving you. It doesn't mean that they checked it and corrected it. So people will auto-populate that. This just blows my mind. They'll auto-populate it and then scan their sheet from the field. It has two completely separate everythings. Like the date of births are wrong, the addresses are different. Well, which is it? Is it the hospital information or is it your information? Again, I rely on you guys as the frontline people to get the right information. I don't want you to be lazy and hit tab space and let it auto-populate, because when it's wrong, who am I coming after? I'm not going back after the hospital. It's on you guys to get it right. So don't fall into those traps. When you get Epic, don't fall into that trap. It's laziness is all it is. Alright, mission specifics for patient information. Again, we talked about this. Unit, crew, team type. How was it dispatched? How did you respond? Where did you respond from? What was your response mode? Where did you go? How did you go? And then what was the transport code? We don't worry about transport code at your level, right? We talked about coding in the back end. Additional elements for patient information, the EMTALA form, hospital face sheets. You know, again, hospital, sending hospital and receiving hospital stuff. Other transportation, transport clinical information, and the PCS. Obtain as much as possible. All right, spend the time to take the time to get that information jotted down. You don't need to write novels, but you need to be thorough. All right, signatures. This is where the rubber meets the road. Okay, this is where, and no offense, your true laziness shines. Oh, you're lazy. Okay? Absolutely lazy. Needs to be done on all patients. Say it again. Needs to be done on all patients. Okay? If you do a round trip transport, get a signature to, get a signature from. But Jeff, isn't one signature good? No. Get a signature every time. Let the billing company administration worry about it. Alright? If you're getting other signatures, they need to have, needs to be legible, they need to have all of their documentation, all of their stuff with their documentation. Time of service if possible. What's your average transport time for 911 calls to the hospital? What's the quickest? 8 minutes.
10 minutes, yeah.
Okay. What would be the longest?
12. I've had a 47 minute.
Okay. So if you take a patient for 47 minutes and you can't get a signature, we're going to have problems. If you take a patient for 8 minutes while they're in your ambulance, we're not going to have a problem. Unless you transferred that patient, said goodbye, hope you feel better to that patient, went out and talked to that family, said, hey, we did this, this, and this for your family member, and left, and didn't come back with a signature. Now we're going to have a problem. Okay? So, if the patient can't sign, you need an authorized representative. If you don't have that, you need a crew member / receiving facility. That's the contemporaneous, that's like the end-all, last resort. Okay? It is a super important aspect of the billing process, and you need to make every effort available to get it done. So here's who signs. Preferably the patient, right? Best signature to get, makes less work for the field crew, makes less work for billing. The only two reasons a patient cannot sign, and you have to document this, physically or mentally unable or incapable. That's it. Mentally incapable because they're demented and at the time of the transport, they were batshit crazy. Or physically unable because they're unconscious. Okay? But you got to document that. If the patient can't sign, a representative needs to sign, and you need to get that representative to sign on behalf of them. If they're unwilling or unable, the last step is the receiving facility signature. If you have to go to step 3, you want to obtain that signature from the receiving facility's representative, preferably the nurse you're transferring care to. That would be the best person to do that. Because the other part of that is it's a little bit of a CYA for, yes, we took them to this hospital, we took them to that room, we transferred it to this nurse. Okay? And they should have their credentials on there. PCS forms, all of the elements should be included, signed, and dated. They should be dated with the date of the transport. Yeah, there's some gray area, they might be good for a couple days, whatever. I don't care! Transport them today, get it signed today. Right? Fix it, make it right. Alright, don't let those people be lazy. Proper signatures have to be legible. And they gotta meet medical necessity criteria, which we beat up today. Right? Yes, sir.
So on our tablets, when we have them sign, we take a lot of like geriatric patients, and we don't have a pen on some of our, so they have to sign with their finger, and that really, for a lot of older patients, that is, it blows their mind a lot. So they end up just kind of scribbling.
Big yellow box right there.
Alright.
Crap, we don't get our pens.
But if they sign with an X, you guys need to sign, or have a witness sign.
Yeah, big yellow box right there. They can sign with an X, with a crew member signing the witness section beside the line for the patient's name. Somebody has to witness and verify that. And that has to be legible. Yeah, you got a question?
Real fast, if you go to the next part where it said that, right there, representative signature, sisters, one's power of attorney, one's not. It doesn't matter which one signs.
Power of attorney.
What if they're not there?
Unavailable?
Okay, so the sister can't sign. The family
If
member,
the
if they're
family
not
member is
authorized-
willing to do it,
Mhm.
they can be an authorized representative. The ideal case is the power of attorney.
Right.
The other gray area is, well, is it healthcare power of attorney, or is it just legal power of attorney? That's a whole other thing, right?
Okay.
So,
But
what basically
if
all
it's
this is
just
doing is
guard.
this is saying that somebody is acknowledging that that patient was transported by your ambulance service and transported to this destination.
that's what I
If
mean.
somebody is willing to accept that liability or responsibility, then that's okay.
Yeah, because we rarely get the power of attorney.
Right.
That's what I wanted to hear.
Mhm.
Thank you.
Alright, PCS forms, I think we beat them up. Now, you guys are using the Zoll tablets, right? One of the things that came up today up in South Bend is that they're getting problems where people were freehanding stuff in there. You may need to look at what's on the screens and what's with the regular PCSs, and if there's a discrepancy, then you want to fix that. Because folks should not be freehanding the reason why they need it. They should be checkboxing the right appropriateness. This is not a carte blanche for a nurse or a doctor to just say, well, because I wrote it on there, they're going by ambulance. Oh, that's not how it works. Okay.
I don't know what you're talking about.
The medical necessity.
The medical necessity form.
Where it says other,
Okay.
they usually write what they.
Up in South Bend, they're seeing a bunch of doctors or nurses just write stuff in there.
On the paper.
Yes.
Ours looks
Yeah.
different than that, I'll show you
Okay.
guys.
No, I follow. I just had to catch up to where
Yeah.
it was because I thought he was talking about on the computer.
So
No, it is. So so on their tablets, yeah. So on the tablet, if this stuff isn't all on there, then you need to fix it. You need to fix what's
They
on
don't
your
do their
tablet.
medical necessities on the tablets.
Oh, okay.
No,
Well, they
we
did.
do- we
That
do
would be
all
I'm sorry,
paper
that's-
form for
that's
that,
the-
yeah.
that's
That's what we
problem.
have right
Okay.
there. They
Then
fixed it
then
themselves.
this has to. And then you guys scan this.
Yeah.
Yeah. Okay. Then that's why everybody's looking at me like I got
Yeah.
two heads. Okay. Yeah. So up there they had this or some form of this on their tablets, but it didn't have all this stuff, and it had a bigger area to freehand, and people were just writing stuff in. So okay, if you're using this thing, you're fine. That's perfect. But it has to be. This has to be checked. It has to identify the patient. It has to identify the date of transportation, right, transport date, and you have to have a legitimate, legible signature with credentials.
Signature and a printed name.
Yes.
The
If that's
printed
not
name
there,
is very
Validation.
difficult.
if that's not there, you go, I need another one.
I am the
Oh,
medical
you don't know how to do
necessity.
it? I need another one.
I am the medical necessity Nazi.
There you go. That's perfect. All right, almost done. So outcomes. How do we look at? How do we know that we're doing good things? Common issues that we see: non-specific chief complaints. Right. Rule out MI is not a chief complaint. Right. We talked about that earlier. Chest pain is a chief complaint. Non-emergency transport is not a chief complaint. All right. Weak history of present illness and weak exam details. A lack of internal consistency in that PCR. Remember, we're not allowed to tell you what to write. We're allowed to tell you how to write it. That make sense? Subjective observations are common issues. We don't want to use those. Missing information or incomplete information, lack in medical necessity, and failure to transport to the closest facility can create issues for us. They are fixable, but these are the common issues. Why is medical necessity denied? Because we didn't appropriately document the underlying medical conditions. We didn't describe in detail why the patient accessed the healthcare system. We didn't describe in detail why the reason for the transport, and we didn't describe in detail why it was necessary for an ambulance to be used. Common theme there, right? In detail, in detail, in detail.
And in some cases, another thing is past medical history. That has a lot to do with, sometimes has a lot to do with the patient's current situation.
Right. The burden of proof for any of this relies with you guys as the caregivers. She sends you out in an ambulance. It's the only industry, it's the only job you ever have where a boss says, you and you go in a truck, go be with whoever. Have fun, right? Nobody's looking over your shoulder. Nobody's checking in on you. Just kind of go do what you do for 8, 10, 12, 24 hours.
Oh my gosh, the looks I just got.
Right?
Somebody's
Okay?
looking
I
over their
feel the
shoulder
fear.
and somebody's checking in on them, and it's me, and it's not going to stop.
But the burden of proof relies on, it's with you guys. It stops with you guys. It starts and stops with you guys. All right? You got to be, you're the front line defense.
GPS
You gotta make it happen.
GPS and cameras.
All right.
You know I love you guys. Listen.
Monitoring.
Listen.
Cameras.
So let's look at a couple scenarios real quick.
You all don't even know.
So
You
we're
don't
always
even
going to
know.
start with the not so goods. And again, I've been told that this is apparently pretty much this station, so I'm going to just apologize now for calling out anybody.
Why you gotta be breaking my clothes?
I don't like
There we go. All right.
Anyone drive a gray Honda?
What kind of Honda?
Like
Okay.
a nice SUV. Hyundai?
Here?
Hyundai or Honda?
I don't know, she said Honda, so.
It's somebody parked sideways out here towards the ugly yellow and green bus that's here. Is that you?
Yeah.
Can you move it? Denise trying to leave.
Just need more detail.
Denise, the med car driver?
All right. So here we go. Medic 55 was dispatched to
Ooh.
STER for a patient being transferred to University Hospital for further evaluations. Arrived to find laying in his bed with an emesis bag close, stating he felt nauseous even though the nurse had given him Zofran. Alright. During the transport, he said he needed to pee. He took the emesis bag and went pee in it. I explained to him that if he does pee in it, he'll have to hold it for the rest of the way. The patient decided to go anyways and hold on to it. We arrived at the hospital with no problems, and we unloaded the patient and took him to a room where he stood for the nurse, and nurse took over care.
Wow.
I think everybody's focusing on the peeing in the emesis bag.
So, and again, I don't want to call anybody out. But
Oh, no, please.
No.
Kyle,
Me. He's not here, okay.
What, Flanagan?
Or it could have been Tyler.
and
No, that's documented by, it's Sky.
and Tyler Commons,
Oh, okay.
Kyle Flanagan, and Carly Watley.
Okay, well, Mr. Commons has since been dismissed.
So, what do we think's wrong with that?
That is a lot of detail about stuff that doesn't matter.
Exactly. Hospital to hospital transport. No reason in the narrative why patients go into the hospital, and no reason for a stretcher. The guy was nauseous. He got a Zofran. The hell out of my ER. Go wherever. Okay?
Be with God.
Go be with your God. We'll just call them out real quick. Caitlin Aldridge, Jeff Reeder.
It'd be Jeff, because Caitlin's a driver only.
Oh,
55 dispatch to St. Elizabeth East for 78-year-old male going to St. Vincent's 86th Street. Was seen for esophageal blockage. That's good, right? Vital signs and assessment as stated in the report. Patient was stable and transport was completed without incident. Upon arrival, the 86th Street nursing staff was given patient report and paperwork.
That's the whole thing?
That's it.
I have a question though, because this is where life gets interesting. Between computer and, between technology and old school. From the way he said that, that would mean that he filled out the check boxes for everything on that narrative.
Whoa, I'm a biller in Pittsburgh reading this.
Right.
How would I know that?
No, if you're a biller, that's where I was going. If you're a biller in Pittsburgh, are you not looking at the drop-down boxes?
I can read the whole thing 100 times, but wouldn't it be easier if you just write what I want you to write in there and then I wouldn't have to go looking for it? I code 150
I'm old
claims a
school.
day.
I write everything under the
Right.
freaking sun in the narrative.
Right.
But what I'm getting at is that most of these people, if they write it in
So
the
here's the end of it, right? There's no check boxes.
yeah, there they are.
Yeah, if I'm writing my report and I say, I got into the ambulance, I took patient vitals as noted above, and then later I retook the patient's vitals as noted again, I have 2 vitals on there,
Here,
do I have to specifically
Okay.
go in there, right?
look, here's the history. None of that tells me he needs an ambulance. Here's the assessment. None of that tells me he needs an ambulance. Here are the vital signs. None of that tells me he needs an ambulance,
That's what I wanted to hear.
right?
Because basically,
So
the
I'm going to
training
use my
level
mental
is
telepathy
now,
here and say, oh look, narrative's too vague. No information given as to why a patient needs to go by stretcher.
Scroll back a little
You can
bit.
take 10 sets
There.
of vitals.
The signatures, does anybody know what's wrong with those 2 signatures for the crew
Full
members?
signatures,
They're not.
the initials aren't allowed.
They have to be full signatures.
And they have to be legible.
Yes. No smiley faces. No, you suck. Alright.
Slow down,
Daniel
Jonathan.
Slaughterbeck
Oh,
and Alex
Jonathan.
That's not true.
Okay. 22 return trip. Return trip from FHCP wound care, 75-year-old male to residence. Patient in semi-Fowler's position upon initial contact, transferred from bed to stretcher via sheet drag. Rails up, taken to ambulance. Patient assessment and vitals as noted per writer. Alert and oriented ×4 stated he was not experiencing any pain. Vitals remained stable throughout transport. Upon arrival at residence, patient taken inside via stretcher. Transferred from stretcher to bed via sheet drag. Care transferred to spouse. All necessary signatures obtained per writer. Thank you for getting signatures. Right? Every time. But how about you give us a little bit of freaking detail about why we need a stretcher? Take the good with the bad, right? The fact that you got a signature is great. The fact that we can't bill this because there's no medical necessity for a stretcher doesn't help us. Seeing a common theme here? Alright, I think we'll do this one as the last one here. Bradley
Rosine.
and Todd Davis. Alright, here we go.
Frankfurt.
31 dispatch to St. Vincent Frankfurt ED for patient transfer to St. Elizabeth East Hospital. Upon arrival, 68-year-old male patient sleeping in his bed. Patient was pink, warm, and dry. Right? Is that what PWD means?
yeah.
The patient was not pink, warm, and dry. What is pink, warm, and dry? Or was he Caucasian? Is that what you mean by pink, warm, and dry? Right? That's what, when I read that, patient was pink, warm, and dry. So he was Caucasian? His skin, right? Is that what you're trying to say here? Skin is pink, warm, and dry. So then say, patient's skin presented pink, warm, and dry. Anyway. Alert and oriented ×3 when roused. At least not while roused, but okay. Sluggish speech reported to be normal for patient. Patient brought in by EMS for fever and AMS. That's awesome, right? Brought in by EMS for fever and AMS. Chronic renal failure was due for dialysis this day, but transported to ED instead. Patient GCS was 15. That's important, remember. At time of transfer. Oh my God. At time of transfer, a GCS of 15. With no complaints. Patient moved to the cot, secured, covered, and moved to the ambulance for non-emergent transport to St. Elizabeth. I'm reading verbatim. VS, as noted, in WNL, NSR on monitor. Patient rested during transport with no significant changes in VS or overall condition. OA, patient was taken to HI room, moved to HIS bed, and report was given and care transferred to his RN. Bed 31 returned to service. GCS at 15. How come he couldn't sign? Now, remember, there could be a legitimate reason why the patient can't sign. But if you don't put it in there, how is the biller in Pittsburgh going to know? Alright. Let's look at some good ones. Alright. Dana and Lauren.
Dana's your problem child over here that's been asking all the questions.
They're all sorts of problems, sorry.
Alright. Dispatch to FHRED to pick up patient and take to IU RNet for admission upon arrival per received report. From transferring RN of an 85-year-old white male, presents semi-Fowler on cart. Patient is deaf but alert and oriented ×3 using notes to read. Patient with IV lock and Foley catheter. Past medical history of CABG, CVA, MI GERD. Presently, this is good. Presently, patient lives at home by self. Got up at 4 a.m. at 0400 this a.m. to go to the bathroom. Was dizzy but needed to go, was urgent, so he stood and collapsed on floor, hitting head on furniture. Patient was down for about 2 to 3 hours, EMS to ED. Patient x-rays found fracture in left hip. Patient is on Coumadin, but transferring nurse couldn't tell proof CT was done because patient is deaf. I'm not sure what that means, but history was clarified by son. Patient CABG was 20-ish years ago and now has a badly leaking valve. Not uncommon for patient to have a slow heart. You do write novels. Slow heart rate in 40s. Patient to cot via sheet ×3. Covered, secured, interventions maintained. Last pain meds reported was morphine at 0745. Patient to unit, vital signs. Monitor a flutter. Patient asked about pain meds. He said yes. 50 MCQ fentanyl given. Physical exam. Deaf. Pearl. Left eye with bruising around it. Small lac hematoma just above there. Upper regions, abdomen soft without complaint, pain, moderate range of motion in upper extremities and right leg. Left leg with shortening and external rotation. Positive pedal pulses noted. Patient resting. No changes en route. Just as unit was arriving destination, patient given a second dose of fentanyl to help with pain or transfer of care. So you might want to put in there what was your second dose of fentanyl. Right?
It's
Patient directed to room 234. That's good, right? 234. We know where we're going. Report paper, CD, copy of rhythm strips, and patient care signed for receiving RN. Patient signed for consent and billing. Everybody clap for Dana.
Can't wait to read the sequel.
I told you from the beginning that we
All right,
novels.
Dana and Lauren.
Needless to say, we need to for that one.
Okay, so what we get from this is unless you're Dana, your reports suck.
No, what you get from this is training. You know,
So-
that's what it is.
I don't know how I'd be able to, unless I stayed really late, write that long if I were back-to-back runs.
Some of that is a little bit extemporaneous. Like, she put it in there, but I read it verbatim. You don't need all of that. What you need is what we've talked about for the last 2 hours. Why do they need an ambulance? Why do they need to go from point A to point B?
And what kind of care are they receiving at point B?
Right. What kind of care did they have at point A?
Yeah.
What kind of care will they be needing or be receiving at point B? All right. Did that. Okay, we did that. So again, this, we're wrapping up here. It's the key to our success as an organization. It's the key to your success as a provider. Maybe you leave here because you are getting relocated or you are changing jobs for whatever. You are a better provider because you can go to that next place and you can engage those people in what it's like to write good reports, why it's important to write good reports. If you work for other agencies, you should be telling them why it's important to write good reports. Right? The problem is somebody somewhere is going to be your competitor, and they're going to come in and they're going to want to gobble everything up, and they're going to do things bad. And when they do it bad and they get caught, they're going to go away. And what happens when they go away? All that workload has to go somewhere. Guess where it's going to go? It's going to come right here. And it's going to stress you all out. Wouldn't it make sense if we could just educate all the people? Competition is good. We like competition. But it should be smart competition. And it should be competition amongst folks who are doing it the right way all the time. Not somebody who's just trying to put people in their ambulances and run them around and make money. That's not good. Alright? Success is important. Timely acquisition of demographic information, excellent documentation, good coding, submit good clean claims the first time out, we bring in good money, and we surface any of our issues to leadership. Alright? One of the reasons I'm here today is because she wants to make sure that you folks are doing everything right. She wants to make sure that she's getting a message across that's not just her beating you upside the head. Right? I'm a third-party independent person who knows a little bit about what you all do, saying, like, this is important stuff. We should be doing this. Alright? So, here's what we expect. Serves lots of purposes. Each one of them is important. Take it seriously. The billing process is complicated, but it can be simplified. We can help that on the front lines. Alright? Documentation is the best intervention. Paint that picture. Billing and reimbursement is important to the organization. Remember, it's not like people are throwing money at you. We only get paid if you take them to the hospital, and we only get paid if you take them to the hospital, and we submit good claims. And we're all doing this together. Ta-da! Questions? Informative? Full of shit? Good?
Nate and I have
Not
had this
good?
conversation with several people. Our goal is to take care of that patient.
Yep.
That patient is someone's grandma, someone's grandpa, someone's mom, someone's dad, so on. They all have their insurance, like you guys have your insurance. Best possible care is to make sure, one of the things for best patient care is to make sure that that patient doesn't get the bill if they shouldn't.
Right.
And for you guys to do everything correctly so that patient doesn't get the bill. And as I said it right in front of Nate, and he agreed with me. If there's anybody in this room right now that doesn't care if a patient gets the bill when they shouldn't, there's the door. Our goal is to make sure that they get the best care possible.
And 90% of the time, that's not even clinical. Honestly, it's not, right? It's about hand-holding, taking them to the right facility, making sure they're getting good quality whatever. Nobody's going to remember how many times you shocked them or how many times you stuck them with an IV. They're going to remember that you were rude to them, that you didn't wipe your feet, that you told them they weren't going to get a bill, but they did. Like, people will remember that stuff. Nobody's smart enough to understand what it is we do, right? Like I said, we put people in trucks and just go be with God, right? Nobody has a clue. You know, I spend a lot of my time educating the community because we don't run a lot of lights and sirens, but when people call 911, what do they expect? Boom, your lights and sirens, you're coming, you're right here, you're right now. So when my crews turn down their street, drive past their house, loop around in the cul-de-sac, come back and pull up against the curb, we haven't even made it in the house yet, and what's that impression?
They were lost.
They
They
don't
missed that
care,
house.
right?
don't know
They
what
were
we're
lost, it
just
took them
doing.
forever,
Yeah.
it wasn't an emergency to them, they didn't come lights and sirens. None of that is true, right? We didn't come lights and sirens because we know it's an increased risk and liability. And your care, what you called for, doesn't warrant it. We drove past your house to turn around because all of our stuff to get out of the medic unit is on the curb side of the ambulance. And now we're facing out of your neighborhood. So when we put you into the ambulance, guess what we do? We just leave. We don't have to take you down your street, turn you around in your cul-de-sac, turn around in the neighbor's driveway. But nobody expects that. All they see is, we haven't even talked to them yet at the door. We didn't use lights and sirens to get there. We drove past your house because we didn't know where the hell we were going. I get that all the time. But we set up our ambulances specifically to do that. Everything's on the curb side. That's against the curb. You're safe. That's where you get everything out. And we don't run, right? Nobody runs. Right? Yeah. Okay. This is the last thing I want to share with you. So this is the compliance part of everything. QuickMed has, I don't know what the number is now, but it's a pretty substantial number of clients all over the country. Cranberry Township EMS, where I serve as EMS director, is with QuickMed claims. If Cranberry does something that's wrong, that gets QuickMed investigated and audited, guess who else gets looked at in that scenario? Everybody else. So I'm here to say, if you all mess it up, I got guys knocking on my door. making sure I'm doing it right. So I have a vested interest in this. So don't mess it up. Okay? But that's that higher level stuff. Like that's for the managers to worry about. But it's huge. So that's why they're a little bit particular in the folks that they allow to come on board. Because they want to provide good, solid coding and reliable reimbursement processes. If you haven't met Gary, he's a good guy. Here's his contact information. And that's it. Make sure you signed in so you can get con ed for it.
That compliance hotline number, are you?
Thank you.